Good evening, everybody. I am Dr. Sanjay Anvekar, working as a consultant orthopedician in Sri Gokulam Hospital, Salem. Today, I shall speak about orthopedics in general. Orthopedics has been there since time immemorial. It was there before World War I, and it is still continuing now. Before World War I, not much was known about orthopedics, but after World War I, orthopedics has really picked up. Why? Because during the World Wars I and II, there was a lot of mortality, lot of morbidity, and this created a greater awareness for orthopedics. Initially, what does orthopedic include? People generally think orthopedic means bones. Okay, it's not only bones; it also involves the tendons, the ligaments, the joints, the nerves. Okay, so orthopedics includes a whole variety of things, but mostly it involves the bones. As we have developed, there has been speciality with respect to each part of orthopedics. There is a specialist for doing a joint replacement. There is a specialist doing just nerve injury repairs. There is a specialist just doing trauma injury. So as we are coming to the coming towards the 21st century, each department has its own speciality. I shall be speaking about orthopedics in general. Now coming to fractures. What does fracture mean? Okay, to a common layman, fracture means break in the bone. So any bone which is broken is a fracture, and it's a grievous injury. Okay, and it needs treatment. Okay, what treatment it requires can vary. It can be managed with a plaster, it can be managed with a bandage, or it might require some form of surgical procedure. Okay. In the olden times, most of the fractures used to be treated with bed rest and some form of native treatment. But as of today, there is a shift in this treatment paradigm, and we are more and more opting for operative treatment. So coming to fractures, from individual fractures. Okay. In the upper limb, we have the shoulder joint, we have the arm, we have the forearm, we have the elbow joint, we have the wrist, and we have the hand. Okay. So in the shoulder, shoulder girdle is made up of three bones in general. You have the humerus, you have the scapula, and you have the collarbone, that is known as the clavicle. Now, most of these fractures, all these three fractures happen because of fall in an outstretched hand. That means patient falls down, and as he falls on his hand. And when he falls on his hand, the force goes along the arm, and that causes the fracture. So, in coming to these three fractures in individuality. Collarbone, that is clavicle fracture. Clavicle fracture is a very common fracture. In fact, it's the most common fracture which happens during delivery. Okay. What is the treatment? Most of the clavicle bone fractures can be managed conservatively. Okay. Does that mean to say that they don't require operative treatment? It's not to say that. They do require operative treatment, but that's case based. Okay. Most of these fractures can be managed with an arm sling. Okay. Earlier we used to use clavicle brace, but that is no more used nowadays. Now the standard conservative management, conservative means not doing any operation. The standard treatment for a clavicle fracture is just a plain arm sling. Okay. Arm sling immobilization of the shoulder for about 3 to 4 weeks, and then followed by gentle range of movement exercises. Very occasionally we do fix clavicle fractures when it is badly comminuted, when it is an open fracture. What does open mean here? Open means the fracture has broken through the skin and it's lying outside. So when there is an open fracture, we do fix the clavicle fracture. Sometimes the clavicle fracture is, along the clavicle fracture, you can have nervous injury, you can have brachial plexus injury, you can have the subclavian artery, subclavian vessels injury. Even in these scenarios, we can fix it. Okay. Sometimes the clavicle fractures happens along with injury to the ligaments. So in this scenario, not only fixing the clavicle fracture, but repairing the ligaments is very, very important. This is in brief regarding clavicle fractures. So most of the clavicle fractures can be managed conservatively. Some do require surgery in the form of plating. Some require extra treatment in the form of plating plus the ligamentous injury repair. Coming to the second bone which in the shoulder, that is the scapula. The scapula is in the back. It's a flat bone, broad flat bone. It also has different parts. Okay. Now again, most of these scapular fractures can be managed conservatively with an arm sling. Okay, that's all what is required. Only when it involves the shoulder joint, that is the glenoid, that's when it requires surgery. Again, coming to involvement of glenoid, it's very rare. Most of the scapular fractures involve the body of the scapula, and these can be managed conservatively. Coming to the third bone which forms the shoulder joint, that is the humerus. Okay, this is the most important bone of the shoulder joint. Okay, again, most of these accidents are due to fall in outstretched hand, and also because of road traffic accidents. Okay, fall in an outstretched hand, this commonly happens in the elderly population, in whom the bone is already of a weak quality, and you can have fracture of the humeral head. Okay, here the treatment has changed. Initially, in the olden days, the treatment used to be arm sling, or maybe a used slab, a crepe bandage. But nowadays, the treatment is more and more definitive towards operative treatment. Okay, we have specially designed plates known as Philo's plate for fixing the upper end of humerus. This gives good stability, and we are able to mobilize this patient very early. What are the disadvantages of not doing a surgery? Patient is kept in an arm sling, and that makes the bone more osteoporotic, that leads to stiffness. Whereas what is the advantage of doing a surgery? We are able to mobilize we are able to get a better fixation, a more aligned fixation, and we are able to mobilize the patient early. Patient is able to get to do his daily activities on an early basis, and that reduces the morbidity to quite an extent. This is regarding the shoulder joint. Just below the shoulder joint, then you have the same humerus bone, the main part of the humerus, that's the shaft. Shaft means the main part base. Again, you can have different types of fractures. You can have closed, open. Closed means where the fracture has not come out. Open means where the fracture has come out. Okay. Why these two differences basically? Closed, where there is less chance of infection, whereas open, since the bone is already come out, there is contamination, there is more chance of infection in open. So we need to differentiate between closed and open. Again, in open you can have variety of open, less than 1 centimeter, more than 1 centimeter. You can have open with the neurovascular system bundles involvement. Closed. Coming to closed fractures. Again, closed fracture of a humerus can be managed conservatively with a used slab, with a cylindrical cast, or you can go for operative treatment. Nowadays, again, the tendency is to more often to go for operative treatment. Okay, you can open the shoulder, you can open the humerus from anterior aspect, from posterior aspect, and then fix it up with a plate. Okay, nowadays quite good plates are available, and you can fix it up you can get a quite good fixation. If not plate, you can even nail the bone. It's a hollow bone. You can even do nailing for humerus. The advantage of doing a humerus nailing is we don't have to do much of soft tissue exposure. So the soft tissue damage is less in a nailing. But still, most of the people prefer plating compared to nailing, because plating gives a better alignment when compared to nailing. Again, these humerus fractures can have sometimes complications involved with them. Some of the humerus fractures can have nerve injury, some of them can have vascular injury. The most common nerve which is involved is the radial nerve, and whenever there is a nerve injury or a vascular injury, that is an indication for surgery basically, because we need to see whether the nerve is entrapped, the nerve is cut, or what has happened to the nerve, so that we can repair it basically, and so that patient can recover. This is regarding humerus shaft fracture. So the most common thing what we do for humerus shaft fracture is nowadays operative treatment, either in the form of plating or in the form of nailing. Very rarely do we do plaster application for these patients. Coming still down, we come to the elbow joint. Now elbow joint contains 3 bones: the lower end of the humerus, the upper end of the upper end of the 2 forearm bones, that's the radius and the ulna. Again, most of these fractures are due to fall in outstretched hand or due to direct injury to the elbow as such. You can have fractures of the lower end of humerus, you can have fractures of the radial head, you can have fractures of the ulna, or you can have fractures of all the 3 together. And most of these fractures do require surgical management. The only exceptions where they don't require surgical management is when it's undisplaced. when there is a hairline crack, undisplaced fractures, at that point of time we can maybe manage these patients with a plasters, an above elbow slab or above elbow cast, but most of them do require some form of surgical management. Coming to the lower end of humerus, it's quite a complicated fracture because it forms the main part of the elbow joint, and most of the time it's shattered into many pieces. So we need to reconstruct each part and then fix it up with plates. We generally require plates on both the sides of the humerus, both on the medial side and on the lateral side, to get a good stable fixation. Coming to the radial head fractures are most of the time undisplaced, okay, and they can get away with just a plaster cast application for 3 to 4 weeks. When the radial head is involved more than 30%, it requires fixation either with a screw or with a plate. Next, coming to the olecranon. Olecranon is the upper part of the ulnar bone. Okay, again this can get fractured when there is a fall in the outstretched hand or due to a direct trauma. Most of these fractures require surgery. Okay, the surgery is either in the form of a tension band wiring or a plating. Tension band wiring generally means that we put wires and we put SS wire, which is it has been used since decades, and we still continue to use it. But nowadays the tendency has been to gradually being shifted towards using plates. Okay, the advantage of plates is that again it gives early mobilization. You are able to get a better fixation and you are able to mobilize much more early than a tension band wire. Coming to the forearm bones. The forearm bones, there are two forearm bones. There is the radius on the lateral aspect, there is the ulna on the inner aspect. Okay, this also can be these fractures can also occur due to fall in an outstretched hand or due to a direct trauma. Okay, again undisplaced fractures, you might treat them with a plaster, but most of them are displaced and most of them require surgery. Surgery is a must in forearm bones. Okay, some other bones might get away without surgery, but a displaced forearm bone without surgery is disastrous, because in between the two forearm bones there is the interosseous ligament. Now any disturbance in the alignment of these two forearm bones causes distortment of the interosseous membrane, and that becomes tight in a mal-aligned position, and then the rotation movements are restricted severely. So forearm bones, if they are displaced, they are a must for surgery. A surgery is must for these cases. Okay, how do you manage forearm bones? Again the old standard protocol, they require fixation using plates most of the time. Very rarely can we put nails. Nails are again, earlier days we used to use nails, rush nails, which are no more used. Nowadays the main treatment is plating. You can make 2 incisions to approach these bones, you can make a single incision to approach these bones and fix it up. Coming to the distal end of the forearm, that's where the wrist comes. Okay. In the wrist you have the distal end of radius, you have the distal end of ulna, and the bones which form the hand, the proximal part of the bones which form the hand, those known as carpal bones. So you have the radiocarpal joint and the ulna carpal joint and the distal radio ulnar joint. Again all these fractures can be fractured. The most common fracture what we see in our day-to-day practice is a fracture of a distal end of radius, commonly known as Colles, named after Sir Abraham Colles. It's fractured because of fall in an outstretched hand, more commonly in elderly patient, elderly female above the age of 60, giving a history that she fell in the bathroom and outstretched hand and her wrist joint is swollen. So most of the time this is what the patient gives a history, and this is the most common fracture seen. The treatment for Colles fracture is still a below elbow cast. Okay, it was being used earlier, it is still being used for about 80% of cases. Still we do a below elbow cast. Remaining 20% of the cases we can go for surgical fixation. The surgical fixation can be either you can open it up or you can not open, you don't need to open it up. If you don't need to open it up, you can just reduce it under the C-arm guidance and put wires. If you want to open it up, we make an opening and then put a plate and fixing it. Again, some might ask why 20% should go for surgery. The same thing, the same principle. With surgery, the stiffness is less. With surgery, the patient resuming his lifestyle, normal lifestyle is earlier. So with surgery, the deformity correction is much better. Okay, but that does not mean to say that cast application does not gives a very bad result. No, it gives quite a good result. But still, surgery is still preferred. even though surgery is only performed in about 20 to 30% of the cases of Colles fracture. Next, coming to ulnar, lower end of ulnar fracture. Ulnar fracture, again, if it is displaced, surgery is required. If it is undisplaced, a cast application. It's very rarely fractured case. Okay, isolated ulnar. Only ulnar fracture is not known as a nightstick fracture. Nightstick means basically patient. It's just a single bone injury, very rare, because you don't get it. So why nightstick? It's known as nightstick because patient was got injured at night. In a humorous way, it's night because someone has attacked him and he has kept his hand like this and it has hit on the ulna. So in a humorous way, it's named as nightstick fracture. Next, coming to the carpal bones. Among the carpal bones, I will not talk about all the carpal bones. The two bones which I will talk about are the scaphoid and the lunate. There are totally 8 carpal bones, among which scaphoid and lunate are worth mentioning. Scaphoid is what just below the radius is the scaphoid. Why is scaphoid important? Scaphoid is important because if the scaphoid gets fractured, it can go for avascular necrosis. So what does avascular necrosis mean? Avascular necrosis means that the bone stops getting its blood supply and the bone becomes dead. Okay. Scaphoid is a very common, notorious bone known to go for avascular necrosis. So the scaphoid is one of the rare bones where you need to get good alignment, good fixation, stable fixation, okay, and a prolonged immobilization. Okay, you might have seen many patients with fractures. They keep the plaster for about 5 weeks, at the maximum 6 weeks. But scaphoid is one of the bones where you keep it for even 8 to 9 weeks, because you don't want that bone to go for avascular necrosis. You want it to join properly. And so what will happen if it goes for, you might ask, what will happen if it goes for avascular necrosis? If it goes for avascular necrosis, the wrist will go for arthritis. Patient will have constant pain. Patient will not be able to do his daily activities. Okay. So as you know very well how important the wrist is. Of all the joints, the wrist is the most, because wrist is used for grasping all the things. So you can just imagine if the patient has pain when holding things, so that how much difficulty it would be causing to the patient. So scaphoid bone is a notorious bone. Sometimes scaphoid bones fractures are not seen initially, and we send the patient telling them that there is nothing much there, just apply ice packs, come back after 10 days. After 10 days you get a repeat x-ray, you see a fracture there. So in case you suspect a scaphoid bone fracture not visible on an x-ray, go for MRI. If a MRI picks up a scaphoid bone fracture, either fix it up or put a plaster for at least 8 weeks, minimum 8 weeks. Fixing is ideal. Coming to the second carpal bone which I mentioned, lunate. Again, lunate is also the same thing. It also is known to go for avascular necrosis. Only good thing about lunate is it does not get fractured that often as scaphoid. But again, if a lunate is fractured, it also needs to be fixed appropriately. Coming to the next, after the carpal bones, we have the metacarpal bones, we have the phalanges. Okay, you can have metacarpal bone fractures at different points. You can have it at the head. Head means the knuckle part is known as the head. Okay, then you have the neck. Just below the knuckle part is known as the neck, and then is the shaft. So you can have different type of fractures. Okay, you might be a fighter, you might be a boxer. You can when boxing you can have a fracture. That's known as boxer's fracture. That is the neck of the fifth metacarpal. So the different types of fractures can happen with different bones. Most of them can be managed with a cast applied or a slab applied in a functional position. The functional position for metacarpal and a phalanx fracture is known as a cobra position. This is the position what we put a plaster in. Okay, this position keeps the ligament in the maximum length, and that's why we put them in cobra position. Again, these can be managed with fixation surgery. The fixation method most commonly used are just plain K wires. You need not open the fracture. Under the CM guidance, we can just reduce the fracture and put wires. Okay. Again, after wires, you can mobilize them early. In the olden days, after putting the wire, people used to wait quite a long time before they remove the wire. But I have noticed that the more longer you wait, the more stiffness it develops. So I ideally remove the wire at about 3 weeks time and start mobilizing the patient. Now that I have mentioned about fractures, I will put a small word about dislocations. The most common dislocated joint is the shoulder joint. Again, the mechanism of injury is a fall in the outstretched hand. You can have different types of shoulder dislocation. You can have an anterior dislocation where the shoulder joint comes anteriorly. You can have a posterior dislocation where the shoulder joint goes posteriorly. You can have an inferior dislocation where the shoulder joint goes inferiorly. Anterior is the most common dislocated joint, and it accounts for about 95% of the patients. Dislocations are very painful. They are actually more painful than fractures also. Okay, and they need to be reduced immediately. Most of these dislocations can be reduced in our OPD itself. Very rarely do we take to the OT to reduce this. Okay, there are various techniques for reducing a dislocation. One of our Indian doctors by name Prakash, he has described a technique for dislocation which is quite easy. Okay, you just the dislocated arm, you just need to keep it like this in this position for about 1 minute, and then slowly adduct it and then rotate it back, and it reduces by itself. Okay. So this is a technique described by Dr. Prakash. It's quite often used, it's quite easy, it's quite patient friendly. Next, coming to posterior dislocation. Posterior dislocations are rare, accounting to about 5% of the cases, and these are more common in epileptic patients. Okay, you have a fits, your hand goes for twisting movements and it dislocates posteriorly. The next, coming to inferior dislocation. Inferior dislocation is again fallen out when someone hits you from the top. When there is a force from the top, your full bone goes down. That's known as inferior dislocation. All the dislocations can be reduced. Okay, what is important is not only reducing the dislocation. The post management of a reduction is very important. Okay, a young patient who has had dislocation is more likely to have recurrent dislocations in future. An elderly patient who has had dislocation will not have that many episodes of recurrent dislocation. Why is this important? Basically because in future, if patient has recurrent dislocation, that means there is some problem in the stability of the shoulder and it needs to be managed. Okay, so post dislocation reduction, we keep the patient in an arm sling or a shoulder immobilizer for about 3 weeks, and at the end of 3 weeks we get an MRI done. MRI is MRI along with the CT to see how the muscles are intact, or whether they are intact, whether they are loose, whether they are torn, to make it whether there is a Bankert's lesion, whether there is a Hill-Sachs lesion. These are little difficult terms, but this is what we look for. If any of these lesions are there, it requires an arthroscopic surgical repair. Okay, why I mentioned arthroscopic, basically because nowadays no one does open repair of these procedures. We have moved away from open. We are nowadays doing only arthroscopic surgical repair of all these lesions, the Bankert's lesion and the Hill-Sachs lesion. Next, coming to the elbow dislocation. Elbow dislocation also can be due to fallen outstretched hand. Okay, when you have a fallen outstretched hand, your olecranon and the radius head dislocates posteriorly, never anteriorly. You never get an elbow dislocation anteriorly. It's every time posteriorly. Again, the same protocol. They are very painful. They need to be reduced immediately. So in the ER itself or in the OPD, you can just give traction and it will reduce by itself. Once it's reduced, you put a plaster and then you get an X-ray. And if there is a fracture, then you can manage that side by side. Okay, but dislocation as such, both shoulder, elbow, most common dislocations can be reduced in the OPD, can be reduced in the ER. Very rarely do we take them to the OT. Okay, so what would be my take-home message? Okay, my take-home message is whatever you do it perfectly. Okay, whether you go for a cast treatment or whether you go for a surgery, it has to be done perfectly. It has to be done to the 100% satisfaction of the patient. Okay. If you ask me what I would advise, whether cast or surgical management, it would be case based basically. But a surgical management does have benefits much over the conservative management. What are the benefits of a surgical management? What we have, the first major benefit is we get a proper alignment. Okay, and as I told you, this alignment is very important. In a single bone, a little bit of malalignment you might get away, but when there are two bones and both are in malaligned position, the movements are restricted. So it gives a very good alignment. The second benefit what we get with the surgical management is we can mobilize the patient early. Okay, just imagine a patient having a leg bone fracture and is put in a plaster and is not able to get out of bed for about 6 to 7 weeks. And just compare the same scenario where you have operated the patient and patient is walking the second day itself. So this is the most important benefit of surgical management is patient is able to mobilize early. The third benefit is stiffness. The stiffness is not there in surgical management as much as is there in conservative management. Because in conservative management, when you put a plaster for 3 to 4 weeks or maybe 5 weeks, 6 weeks, all the structures around the joint, around the bones become stiff. And once you remove the plaster, movements of the joint is grossly restricted. Whereas in surgical management, we are able to start the range of movement exercises from day one itself. And that's why the stiffness is less. Thank you, my dear friends and colleagues. We shall meet shortly.